Welcome. And what I thought I would do is show you some slides and see if we can cover a little ground through that. So give me 1 sec and I'll pull that up for you. Great. So just to double check, maybe Rick, if you can let me know if you see the, if you can see.
Everything looks good, Brad.
Great. Okay, great. Okay, so again, please feel free to add stuff into the Q&A as we go along so I can sort of mix in some of your questions in a timely manner, or we'll catch them on the backside. And we'll talk today about COVID. So what I want to really focus on is thinking about prevention strategies, treatments, talking about vaccine, and then just to like take a breath for a moment, maybe we can do that right now, and just take a big sigh, take a big breath, and just relax, feel into our bodies, and come down from our minds a little bit. I know I need to do that when I'm running around. And so we can hear this from a greater perspective. So what I'd like to do is just sort of start off with a question. Someone asked, how secure do you feel about test and gather strategies? I want to see my 79-year-old mother for Christmas, and I wonder about testing and quarantining her to protect her. What's the best test for this? How many days of quarantine? So I don't know about the gather part of the test and gather strategy, but what I take this to, I know a lot of people, including my mom's in her early 80s, and if we want to come together for the holidays, what does that look like? In general, I think people should avoid far distance traveling. In general, definitely avoid air travel. And if you're going to travel, do it in cars and do it in a safe way. And if you're ideally local and you're coming to visit someone else, you can test, and I'll show you some different testing machines that are available. And the quality of the testing machine is dependent on that machine. And I'll speak to that. And then there's a window there. So if you were to be exposed by somebody, it would take about 3 to 7 days. So we typically say day 4 or 5 before we'd want to test you. And so if you got tested today, but you were exposed to someone yesterday, then you might miss that window where you got exposed yesterday, you got tested today, you went and saw someone 3 days from now, mom comes to see you 3 days later. And now what was a very low amount of virus that may have been missed, theoretically could have been missed even from a PCR test. Now by day 4 is a robust amount of virus in the body, and now you could be infectious. So that's theoretical. For most people, we really try and have used testing to diagnose someone who's been exposed in the past. All right. So dropping into our quality of being for a moment and reflecting on taking our nice deep breaths and dropping into ourselves. These are different sorts of machines you can play with. The White House and Dignity Health and a lot of these companies have this machine here, which is called the Abbott ID Now machine. And a lot of other ones have this antigen machine over here to the right, the Quiddle, Sophia too. Those aren't quite as good as the rapid test Cepheid. We just purchased this, actually, the rapid test Cepheid machine, which is a PCR-based machine, which is what all the countries require if you travel to Bahamas, Hawaii, Fiji, and French Polynesian Islands. They're all requiring a rapid test PCR machine because it's the most accurate. And that can be done in the lab, typically UCSF, Quest, Stanford. They all do the PCR machines on these large machines. that Roche and others make. We were able to secure this machine, the Cepheid, and so we're running those tests now in our office. The limiting factor for us is getting the actual tests now, this blue thing, that little cartridge that drops in there. It'll test for flu A, flu B, RSV, which is respiratory syncytial virus, and COVID. So it's great. Very rapid, very reliable, very sensitive test, like 98, 99%. They say 99% accurate. The Abbott one is somewhere between 50 and 80% accurate, or actually 91% accurate. And the 90, this one says 50 plus, meaning that the accuracy really relates to the time when I was talking about earlier, when you're most infectious. So if you're infectious, you have enough virus in your body that these machines like the Abbott ID now will pick it up. So the reason some of the tests you may have heard for this machine, some of the studies showed it was only 50% accurate, is because they were comparing it with a PCR test, like the one on the left that we have, and which is the gold standard, and it will detect before you're actually infectious at lower viral particles. So, but if you take someone and test them 5 days out from their known exposure, when they're most likely to have the most virus and most likely to be infectious, then this machine, the Abbott ID, performs better, upward towards 91%. And so you can imagine if you do it twice, then you have a 9% chance of a false negative, meaning it says I'm negative, but there's a 9% chance it's wrong, I'm actually positive. So if you do it again, now you've got 9% times 9%. So it's a less than 1% chance now if you do it twice that you would miss it. So assuming it's within that infectious window. When you're just outside the window, either too early or too late, the PCR test will pick it up, but these other ones won't because there's not enough virus in there, which is partly why President Trump, if you notice, didn't really want to get retested later on, because he knew it would be the PCR test and it would still show him being positive, even though he wasn't necessarily infectious. So anyway, so these are the different tests that are out there. And then you've got the home tests that are sort of on the horizon. Lucira being one of the ones that are well known, and they're trying to ramp up manufacturing over the next several months. And hopefully by prescription, this test will be made available, and we should be getting some of this ourselves in Q1, we hope. And these are by prescription. And the early data on this is it's quite accurate. They say it's as good, 98% accuracy. So with respect to, false negative rates, this is using something called the LAMP technology, which is sort of a variant of PCR. So that's exciting. There's a lot, then there's a range of home tests, other home tests that use the antigen approach, which, this one on the far right here, that aren't as good. And, you can see a sensitivity of 80% and worse. A lot of these home tests may have. So I'm not a fan of those because it gives you the false sense of that you're safe when you're really not. Okay, so let's sort of the diagnostic testing question. I hope I answered that successfully. And basically, in short, get a good test for grandma or mom or you, a day or two prior. And if you're going to come together, I would still do social distancing and use a mask. And, there's no harm in being safe. I would use HEPA filters in your house, have windows open if you're going to do it indoors, even if you've been tested negative. It's just not worth the risk. And so if you're going to test, great. And also do these other precautions that we recommend. Someone else asked, do we need to worry about packages and things on packages? Now, Anthony Fauci says, no, hopefully most people are over that. I will say that, if someone sneezes on your package and puts it down on your front door and then you pick it up with a bare hand and wipe your nose within, half hour of that person, then yeah, it's theoretically possible you'd get it from them. What are the odds of that happening? Pretty low. What do most people do these days? They sort of let it sort of sit for, several hours and then they bring it in and open the package. Odds of getting it through packaging is, in groceries, et cetera, is quite low from sort of contact. Because, it's now if someone sneezed on a countertop and you go to the bathroom that they sneezed on that countertop and you happen to wipe your hand on it and touch your face, you could theoretically get it. It's much more likely it's going to happen though through respiratory a droplet transmission from being in close proximity. So the other question here is, my daughter works in a grocery store. She's careful and logical. She loves her job. She enjoys it. How can we protect her beyond the usual protocols? So, I mean, the usual protocols are really the only means. And then also she herself having a good immune system, right? So getting good sleep, managing her stress, exercising, eating well, so to keep that immune system well, sleeping well, because we know sleep is a huge part of maintaining our immune system. So, that's a big piece of the pie, is improving your own immune system so that you can resist it. And what kind of mask do people wear? I'm a fan of the surgical masks that we know that's most effective. Cloth masks we know aren't as effective as surgical masks. So I recommend people wear surgical masks. And if they're going to wear cloth masks, then to put the filters that drop inside, like those coffee filter designed filtration systems. And they even have them that are actually pretty well designed, that are actually above and beyond the typical filters. You can also drop in those filters inside the cloth mask. So those are the main things. People are using other sorts of things that, we don't know. People are using copper impregnated, cotton that has copper in it, or other sort of minerals that they think have viral properties. But that stuff is just not really super well studied. Should we declare a threshold when we think it's unsafe for her to work? Number of cases, and et cetera. And, they do that in a way with respect to the different tiers, and we are in the purple tier, which is the highest tier. But beyond that, I think it's really, a matter of common sense. And unfortunately, there are no absolute numbers. There are no thresholds. We do know that you can be, we treat people as doctors treating people with COVID and don't get COVID, as long as we're wearing the proper equipment and are keeping ourselves distant. So ideally, the work environments we're in, if we're inside, it's well ventilated. There's filtration system. The windows are open. That's the most important part. Indoor air quality is really important. Bill Hayward spoke to that last time, and if you're curious more about that, you can go onto my YouTube channel and look at that. It's a great conversation with Bill. And it's really about opening the windows, having HEPA filters in place, improving airflow, and then, of course, distancing and masking. So if we look at the numbers here, United States is clearly an outlier. You could see here how there's really, this is the daily new confirmed cases per million. And you can see that us leading the pack, sadly. You could see other countries actually getting things a bit under control. But I believe that's Italy that had the big spike, and then, actually, no, that was Switzerland, I believe, that had the big spike and then came down. You can see here on a daily new confirmed cases 7-day rolling average, you can see how we're quite a bit higher with this. The other one was counting for population density. This isn't. This is just raw numbers of number of cases, and we're well above 200,000 a day. So then the other thing I thought would be helpful is looking at a case fatality rate, and this is what this looks at is the number of cases. So that's by diagnosis. So it depends on testing. So the more you test, the lower your case fatality rate goes compared to a country that's not testing a lot, right? So if you imagine if Iran's not testing a lot, then their case fatality rate would be higher because we never really know the infection fatality rate. The infection fatality rate is the true number of people that are infected and how many of them are dying. Case fatalities of those that we test and they're positive, what's the death rate? But you can see, assuming we all test the same amount, you can see, so the world average is 2.3% and we're running 1.9%. But again, this varies based on how much people are testing. And I think our mortality rates, if we were to assume that they're equal to everyone else's, are higher, is because we tend to be a country that is overweight, diabetic, and hypertensive, which we know are all risk factors for poor outcomes. So what I wanted to switch gears and talk a little bit more about is sort of treatment and prophylaxis. And I thought this was, the guys out of Florida have, some of you have sent me the videos of them testifying before the Senate, and other folks have sent me videos of them also just speaking, having their own news conference, begging and pleading for the NIH and WHO and other national organizations and world organizations to come together and review the literature on ivermectin in particular. So I thought it was a nice way, the way they summarize sort of some of the treatments that we've spoken about in previous conversations I've had when I've had these talks, which if you're interested in, feel free to go back to the YouTube channel and see some earlier talks. And so they sort of, the point of this slide is really not, I will talk about ivermectin, but I just want to talk about some other things that I am recommending people take in the hopes that we could help augment the immune system. And in particular, vitamin D, particularly for people that are low, their levels are low. And people take a range anywhere from 1,000 to 10,000 a day, but most people, we're shooting for a vitamin D level of around 40 to 50. And so usually for most people, 2,000 a day is the right amount. Some people need more, depending on how you convert vitamin D, how your gut converts it into active vitamin D for your body. But roughly 2,000 units a day. And vitamin C, in addition, anywhere from 1 to 3,000 milligrams, 1 to 3 grams a day, as a preventive agent as well. Typically, I don't recommend vitamin C if you look at it for like prevention of colds. The data is pretty lukewarm on it. It's for prevention, but actually in acute treatment at the onset, it's actually can be quite effective. But in this scenario, I think there's enough literature out there, and COVID's significant enough of an illness that it's worth taking. The side effects are very few, other than at higher doses, some people get GI disturbance. Quercetin, which is from onions, is thought to have significant effects with COVID, and actually in combination with zinc. So both of those, I tend to recommend more 30 to 40 milligrams a day. They're recommending 50. And then melatonin is thought to have some interesting antiviral properties as well. 3 to 6 milligrams can be taken typically before bed. It also helps with reflux. And so I think that this is a shortened protocol. I'm also a fan of N-acetylcysteine, which we know is good for the liver and the lung, as well as medicinal mushrooms, cordyceps, and reishi and maitake. These medicinal mushrooms are actually thought to be quite immunomodulatory, and you can find those. I'm a big fan of Paul Stamets's products, and he has a company called Host Defense, and so I frequently recommend people take those. So this is a prophylaxis protocol, and I'll talk about ivermectin a bit later. And hopeful that we can sort of review some of that literature. What they talk about here is 0.2 milligrams per kilo. So in general, for a 70 kilogram person, that would be roughly 12 milligrams, 14 milligrams. But it comes in, I think it's 3 and 6 milligram pills. So typically 12 milligrams. And they do it on day 1 and day 3, or day 1 and day 5 for acute treatment. You can see here they're recommending day 1 and day 3, and then 1 dose weekly for 10 weeks, followed by 1 dose every 2 weeks. There's not a lot of data on that, but that's sort of what their recommendations are, and we'll speak to that in a moment or two. Early outpatient protocols, pretty similar. The only difference is adding aspirin, and the reason is that there's a concern about blood clots in general, and sort of the atherothrombotic effects of this infection. It can cause small clots in our body, and aspirin would be able to help potentially offset that. They use low molecular weight heparin in the hospital. So if someone's hospitalized, it would be a different protocol, most likely. In addition, they would potentially add dexamethasone, which is a steroid, and potentially, depending on how sick they are, remdesivir as well. So those, and then, if you're a celebrity government official, you get monoclonal antibodies Otherwise, they're really hard to get. It's a little bit of a jab towards those that are seeking and getting care when they don't inappropriate therapy. So this is the early outpatient protocol. So I thought maybe we'd speak to the ivermectin, since there's a lot of conversation about that. I think the jury's out until we get more information, but I will say the information that I've gleaned so far is pretty interesting and provocative. And as more data comes out, we'll see how things look. But let me show you some of the promising data, at least. The background is this medication has been used since the mid-70s. Actually, the guys that sort of found it, discovered it, and developed it in 2015 got a Nobel Prize in medicine for it, because it's helped treat hundreds, tens of millions of people with infections as a anti-parasitic. So this is really used to kill parasites. Hundreds of millions of doses are being distributed annually. And the dose range is, anywhere from 0.15 to 0.4 milligrams per kilogram. In general, for COVID, we're dosing it at 0.2 milligrams per kilogram. There is some interactions with blood thinners if people on warfarin. It's theoretically possible that you could have some problems. So if someone is on blood thinners, they should use this a bit more carefully. Most people tolerate it really well. And the serious, what we call serious adverse events, which is the SAE, is very rare, 1 per million. So it's really thought to be quite safe. If at a sort of intracellular level, the thought is if you look at B there for viruses, what happens is the virus, the way it often communicates is it'll package itself in and get transported across this, what's called a nuclear pore complex, and move into the nucleus of the cell, from the sort of cytoplasm of the cell inside the cell. It'll transport in. With ivermectin will block that, and we think that's a main mechanism, will block the virus from getting into the nucleus of the cell, where what happens is the virus then takes over the machinery of that nucleus of the cell and then allows itself to replicate. So the thought is that this thing binds there's a binding site on what's called the IMP alpha, and that prevents this from actually transporting into the nucleus of the cell, which prevents the virus from replicating. And so if you look at a whole bunch of different studies, a lot of these aren't published yet in peer-reviewed journals. So there's a bit of a caveat, because we don't know how good the quality of the study is, or are there problems with the data like that. It needs to be vetted more, but I thought I'd run through a few of the studies so that you can have a better sense for them. This is one of the larger studies. This one used doxycycline, which is an antibiotic, as well as ivermectin, and they did this over the summer. And they took adults, about 556 of them were eligible. They end up enrolling 400, and most of them completed the study. 363 completed. They had equal amounts. It wasn't actually, this one was a randomized controlled trial, and 15 and 17 in the two groups were lost to follow-up. 3 of them died in the placebo group. No one died in the intervention group. Those guys were lost to follow-up too, because they died. Equal sort of loss to follow-up in each group. Sometimes you get a weird result if a lot of people drop out from the placebo group, for example. In this case, it was pretty equal. So everyone got Tylenol, vitamin D, oxygen if they needed it, and what's called low molecular weight heparin for the blood clotting issue, and or dexamethasone, depending on how sick they were, which is a steroid, which is shown to be helpful. And then one side of the group got the ivermectin plus doxycycline. So they got 12 milligrams, one dose of 12 milligrams on day 0. And then they got 5 days of this doxycycline twice daily. And so all the outcomes they looked at were quite promising. So they found that they were 60% versus 44% had what they called early clinical improvement. That's a hazard reduction ratio of 0.5, which is quite promising, and it didn't cross the 1 mark. So it's statistically significant and showed a significant reduction. You see there's a 50% benefit, relative benefit from one group versus the other. right? So you got 44% had clinical improvement in the placebo arm, but 60%, 50% more, which is why the hazard ratio is 0.5, 50% more had clinical benefit in the intervention group. And then they looked to see how many of them cleared their PCR tests. So it was the viral load, that how quickly it dropped. So PCR returned negative if they had complete virus eradication. And you could see here, only 7%, almost 8% in the intervention group were positive versus 20% were still positive on day 12 in the control group. And then they looked at how many had persistent effects, persistent symptoms beyond 12 days. And again, more than a third in the folks that got nothing and only a quarter in those that got the intervention group. And then how many actually clinically deteriorated? Again, you're twice as likely to have clinical deterioration if you didn't get the ivermectin. So 8.7 versus 17.8%. So this was done in Bangladesh and at Dhaka Medical College. So it was done overseas, and it hasn't been peer reviewed, but it was put in sort of the, these pre peer reviewed papers that are going out now. So you could find this on Trial Site News if you're interested in looking at it a bit more. There's a few other studies. There's the ICON study, which was done in Florida. That was a retrospective study looking at moderate to severe COVID patients. So they didn't randomize people in this. They sort of went back and looked at who got ivermectin. In this case, they got dosed twice on day 0 or 1 and day 7. And they showed a mortality benefit and a risk reduction of 11%, absolute risk reduction, which is about as good as dexamethasone. If you sort of compare how good is dexamethasone, which everyone's excited about, also, they got about the same benefit, a 12% absolute risk reduction when you compare the studies. They're different studies in different populations, but the point is that it's pretty robust. Another study called the IDEA protocol. This one was an observational cohort study done prospectively, but it's observational. They don't have a control group. They weren't randomized. And what they found here is they dosed people differently depending on if it was mild, moderate, or severe. On increasing doses, they gave them 2 doses, day 0 and day 7. And you could see here that in the mild group, there were 135 of them. None of them progressed. None of them ended up in the hospital, and none of them died. That's the mild group. And most people that are mild do pretty well in general, but there is a 15% chance that people progress, and here require hospitalization. In this case, that didn't happen. And then the moderate to severe group is smaller, is only 31 folks, but none of those folks progressed, although 1 did die of the 31. So they found there was a mortality benefit when they compared them to sort of the region at large. What they did is say, in this region for people with this severity of illness, what was the mortality, general mortality? And it was roughly 2%. And they found in this group, it was only 0.6%. So they found a mortality benefit. Again, these are not tightly, highly rigorous studies when you look at it like this, but still definitely interesting. And in the moderate to severe group, you could see here, the mortality was 3% versus 25%. So what they're saying here is if you're moderate to severe, you got a 25% chance of dying in the same hospital in the same time frame, versus 3% amongst the small group that got the ivermectin. So it's a small group, 32, but again, this is pretty huge, right? 3% versus 25%. So pretty interesting also. So those looking at sort of treatment, moderate to severe, mild to moderate to severe, there's some other studies out there as well. But these 3 I thought are worth looking at and all showed positive results. Now, what about prophylaxis? None of these are randomized studies, but they're really interesting to look at. So one group, and this is sort of you can find these on clinicaltrials.gov. But you can see here they had one group was a whole bunch of healthcare workers, and they got 6 milligrams of ivermectin. In this first study, they got carrageenan, which they sprayed into the face mask, and they would sort of use those and inhale those as well. And in this situation, 11% of the folks that didn't get anything got infected over this time period that they were studying these healthcare workers. And none of the folks in the 131 people that got the ivermectin and this carrageenan were infected. So that you could see here, roughly what, 11% of 98, so roughly 11 people, 10 or 11 people were infected versus 0 people in the other group, prophylactic use. Again, another one is these are household contacts. So my wife gets infected, the family and kids now are household contacts. What do we do? If you give them ivermectin, what happens? In this scenario here, they gave them dosing roughly 12 milligrams for most people, probably on day 1 and again on day 3. And then they compared it to a group that got none. I don't know how many people, got none versus how many did. There's not details yet. But you can see here that 7% versus 58% were symptomatic. So huge difference there. Again, we don't know how rigorous the studies were, but pretty provocative. And then finally, the Behera et al. Study here took matched case control pairs of healthcare workers. So they tried to pair folks up and control for certain factors on their exposure rates, 186 of them. They split them into 2 groups. And then you can see here, there was a 73% reduction in the infection rate amongst those that got ivermectin. So again, pretty provocative, pretty exciting. And so where do we go from here? So, just to take a moment and sort of chat a little bit about this. What the biggest issues here are really around safety, cost, and really sort of, I would say, the first 2 issues, even if you put aside how effective it is or not. And this looks like a pretty safe medication, except for those on blood thinners, has to be more cautious about that. It's pretty inexpensive. It's widely available. Now the question is, how effective is it? We went through this with hydroxychloroquine, where we found out it wasn't effective. People were very excited about it. There was early data that was exciting, and then it all became for naught. And then it turned out we found out that people could have QT prolongation, where people are prone to arrhythmias, and there are other concerns. And so we realized actually we're causing more harm than good with hydroxychloroquine. So I'm a little bit hesitant to jump the gun on ivermectin because we know that good data is important to have. With that said, this looks pretty promising. So my intentions are to do a bit more research. There's been a call and a request for the NIH to review the data and WHO to review the data. I'm hopeful in the next month we'll hear from them on this topic. And I'm hopeful that some of these these studies that haven't been peer reviewed yet will be peer reviewed. And then we can really look at the details of the data, and that'll be helpful in the next weeks to come. There is an argument, and these guys do argue out of Florida, like it's safe enough, we have enough preliminary data, why don't we just give this to everyone? People are dying, and there's a good argument for that. So I think it's important to talk to your docs about this and have that discussion. All right, so let me go back to show you some more slides. I want to talk a bit more about the vaccine. So let's see if you can see that. Vaccine. So someone asked me, I have anaphylaxis to nuts and nuts products, and I'm learning about adverse reactions to the vaccine. What do you know? What do you know about how many more studies and trials would be needed to know if it's safe to take the vaccine? So we have, about 70,000 people have already taken the vaccines between the 2 vaccines, the mRNA vaccines already between the 2 studies, between the 2, Pfizer and Moderna. A lot of people have gone through it. It's been several months. I think the risk profiles are quite safe. I mean, of course, anaphylaxis is possible. But again, so far it looks really good. By the time, for better and worse, by the time most of the general population gets the medicine, millions of people millions of healthcare workers in particular, and the elderly will have received this vaccine. That's good news for those that are sort of waiting later and are concerned about safety. If this was readily available to me, I would take it immediately. I really find this vaccine to be very effective, and the data so far shows it's quite safe. So let's just talk a bit about vaccine distribution for a moment. This is an mRNA vaccine, by the way, and so it's not like you're giving live vaccine to somebody or attenuated vaccine to someone. You're taking the mRNA, which is the messenger of the RNA, and a small little piece of that, and then our body creates an immune response to that fragment, and then it's our immune response that then protects us from future infection. People do get side effects, and it's our immune response that's creating that side effect. As we have this robust immune response, we may get fever, chills, we may get body aches and other symptoms like a flu. Similar to some people have experienced with the shingles vaccine, the new Shingrix vaccine, which is quite effective. So thinking about sort of doses now and how this is distributed through the population, I'll just start by saying, don't expect to receive it for most of us in the audience here until April to June. And the reason is that we have to run through a lot of different populations that are much higher risk first, and there's millions of those people. There's 2.9 million healthcare workers alone in California. So that's requiring a huge amount of logistics, as you know, and then we got to sort of, the good news is once that's sort of worked through, then I think further distribution of the vaccines will go faster and easier week after week, and as production ramps up. So you can see here, we currently have a sort of a constrained supply and limited doses are available with a highly targeted administration. That's where we are right now, where healthcare professionals and first responders are really the first ones getting it. And then it'll move on to folks living in nursing homes, and et cetera. And you can sort of see how this will roll out as the number of doses increases and as manufacturing goes up. And you can see here sort of the phase 1 and 2, 3, and 4. So you've got in phase 1, it's the healthcare workers and first responders. And those healthcare workers aren't me. They're folks in the emergency room, in the intensive care unit, in the hospital, those that are screening large numbers of COVID, potentially infected COVID patients in the COVID screening clinics, et cetera. Then you move to phase B. Phase 1B is really folks that are significantly high risk. So if you're on immunosuppression, if you're a transplant patient with a liver transplant, if you're you have an autoimmune condition and you're on high dose steroids, if you're going through chemotherapy and your immune system isn't working, those are the significantly high risk people. And then folks in nursing homes. And then phase 2 is folks that have a high exposure as well, risk. So, folks that are teachers in schools, school staff, childcare workers. And then you've got folks that are, in the critical workers in high risk settings, and then sort of moves through wave after wave. You can see phase 3 and phase 4. So each one of these phases is going to take, I think the phase 1 will take the longest. And I have a feeling as the phases roll out, we'll have more distribution, logistics will be better, and there'll be larger supply, and we'll be able to actually ramp this up more quickly as we move phase through phase. You can see here, this is sort of per the San Francisco Department of Public Health, Californians anticipate to receive 1 million doses initially. And this is pulled out of some conversations that we've had through the California Department of Public Health and the San Francisco Department of Public Health, and sort of, where it's coming from, how it's being distributed through the different counties and different facilities. So just some basics about the different vaccines that are available now. The mRNA vaccines by Pfizer and Moderna, you can see it's 2 doses. One's 21 days apart, the other one's 28 days apart. As you probably heard, the Pfizer ones need these ultra cold freezers. I think it's negative 90 degrees Fahrenheit. And so in order to store them, the Moderna needs only a negative 20 degree Celsius environment. And so there's huge logistics that are involved around that. So, and then the complexities really are, we got to get a second dose to everyone. That's going to be complex to get people back. The ultra low cord storage requirements makes it harder to find facilities that can store these and get enough of those freezers in place. And we don't really know about the public demand. There's 50% of the population is saying they're not sure if they want the vaccine. So, and these vaccines only have a limited life, storage capacity of 6 months. So we really got to balance supply and demand. The good news is those that want the vaccine, hopefully we'll be able to get it more quickly because not everyone wants it. At a public health level, we really want everyone to get vaccinated, at least 70% of the population, to really get that herd immunity that we need to really end this pandemic. UCSF is sort of prioritizing how they're doing it. This came from one of the UCSF talks I was involved in, that I was part of. And this really focuses on healthcare providers, but you can sort of see how they're, even within a phase 1A group, how complicated this is and how they're having to break this down within groups within that. So you can see how there's really a significant amount of details, logistics that has to go into place. There's a lot of anxiety and concern, understandably. Marin County, I believe, only has one ICU bed available at this point. Really, the hospitals are filling up, in part because we've been taking, we had capacity in Marin County, for example. So same with UCSF. So we've taken on patients where there's hospitals that don't have ICU beds. Nonetheless, that means if someone gets really sick, there may not be an ICU bed available. So I really encourage folks to really be careful. And it's time to really hone in, not accept unnecessary risks. With that said, I think it's relevant to look at your own chance of getting exposed, and you can play with this calculator because it asks you different behavioral questions. And you can play with it saying, yeah, I hang out with friends all day long and I don't keep my distance, and you can see your risk of getting infected versus actually you take the precautions that you think are relevant and important, and you can look at your risk. And then it also will look at the chance of you dying as well. So, and the reason it'll look at that is that, and then it'll combine those two chances of what's the chance of you getting it, what's the chance of you dying if you get it, and then it'll give you overall chance of survival, which is really a combination of, you can see here, a 5% chance is a chance of 1 in 20, a 5% chance of getting COVID. And then if I do get it, I have a 0.5% chance of dying from it. Then you can see that you multiply both of those to say, what's my survival probability, which is quite high. So it's 97.8% or something like that, because you're combining those two. And that's actually in the next slide. So you can see here, it's 5% infection rate, mortality risk is 0.5%. So the survival probability is quite high, 99.97% actually. But we all focus on our mortality risk, but really a big piece of it relates to our infection risk. And that's the one we can drive up and down the most. The other thing I just want to bring to our attention is, even if most of us do well with it, but many of us actually have long-term sequelae from this, where we live with it and we're still having issues. I have several patients that are weeks out, months out, and are still having subtle issues. And there's a study going on at UCSF now looking at what we call long haulers. And so any of you that have had COVID or know anyone that has COVID, I encourage you to enroll in these sorts of studies. There's one going on at UCSF. And then most important really is just taking care of ourselves, really. I just want to speak to the importance of really us taking care of ourselves and our loved ones, and sort of manifesting as much love and generosity as we can to ourselves, to our loved ones, and to the world at large. There's a lot of suffering, emotional suffering, mental health suffering, as well as financial suffering going on right now. And the more that we can put out into the world to sort of stave that off and to sort of generate positive energy, the better. So we're at 7:30. So those that need to leave, feel free to. I wanted to address some questions that were put up. So let me sort of address some of those. So why do so many people still have their mask below their nose? That's a good question. I encourage people to gently and kindly remind them, oh, did you know that your mask is below your nose? Because they shouldn't. We definitely want people covering their masks. And you may see grocers doing that. And so, they're moving and it's falling below their nose. You can encourage people to use tape. If you wear glasses, actually, one of my friends taught me, he puts tape across the top, and that way it doesn't fog up his glasses. It also helps to make it so it doesn't drop below the nose. Do you think KN95 masks work well if you're in a crowded area like waiting rooms? Definitely N95 masks are better than surgical masks, which are better than cloth masks. So yes, if it's a legitimate KN95 mask, then it would be good to use that if you had to be in a crowded space, if you had to go to the doctor and there's crowd. I mean, most places nowadays, there aren't crowded waiting rooms, but definitely N95s are better than surgical masks. I didn't know that quercetin, I think this might be a statement, quercetin's in apples too. But the dosages that you need quercetin in, you can't eat enough onion or apples. So you would take it as a pill. I did say that melatonin does help with reflux. It actually affects the gastroesophageal sphincter. And it's been studied. There's some clinical trials looking at that. And so, yes, it does help with reflux. I mentioned NAC, which is N-acetylcysteine, which is, for example, Mucomyst, which has been used in Europe a lot for folks that go and eat, they go out and forage for mushrooms, and then they eat the wrong ones and then end up in liver failure, sadly. And so they come in, they get put on IV N-acetylcysteine, and it actually prevents liver failure. So N-acetylcysteine, which is good for the liver, also good for the lungs. NAC, N-acetylcysteine. Usually 1.2 grams daily, roughly. It comes typically in 500 or 600 milligram pills. Why would someone take ivermectin if diagnosed with COVID-19? So hopefully I answered that question through the talk. It is a prescription. It is a medication. We don't know how often we're going to need to get a vaccine. It's a great question. We don't know how often this mutates. We don't know how long immunity lasts. I have a couple patients that have had this, and one patient, his antibodies went back to negative again. So he was positive by IgG antibodies, and now he's negative. Does that mean he can get infected again? We don't think so. We think that we have neutralizing antibodies, which are not registered by the antibody test. It's a different class of antibodies. And those neutralizing antibodies will know to sort of knock on the door of the T cells, which is a different immune class, and rev them up to go kill COVID. There's been very few reinfections. There's been a few documented of the millions of cases. So we don't think reinfection is likely, at least not in the near term yet. We don't know how quickly the vaccine will how quickly the virus will mutate. So like the flu mutates a lot. And so we need a new flu vaccine every year because it mutates. Thankfully, thus far, COVID-19 hasn't mutated much. So that bodes well. Maybe we might be able to use this vaccine and get dosed. And hopefully, how long does the vaccine last is one question, that immunity. And then the second question is, will the virus mutate, requiring a new vaccine to be made, different from the previous vaccine you just had? So for example, typhoid, you have to get revaccinated every 3 years, 5 years, depending on what kind of typhoid vaccine you get. And that's because the immunity wanes from that vaccine. It's not because the typhoid's mutating. We don't know how long this vaccine will last. Second question is, how frequently will it mutate, requiring a whole different type of vaccine to handle that new configuration, that new mutation. So what do you recommend for folks that are on disease-modifying drugs for, I presume, for autoimmune conditions? Everything we've talked about so far would be safe for you to take. Talk to your doctor to make sure. I don't know what specific drugs you're taking, but that would be worth a conversation. So I would anticipate that most people, question is about timing of vaccines. Most people will be vaccinated, I would say healthcare workers and nursing home residents and that sort of that very high risk group in the next 2 months. Hopefully by the end of January, they'll be done. Then the next category of risk, over 75, those with high risk or moderate risk comorbidities will be in the next couple months. And then sort of, April to June would be the under 65 group. that's relatively healthy. What's going to be interesting is what's considered moderate risk, because diabetes and obesity, or the preponderance of the United States have that, those diagnoses, and that puts them at increased risk, which means that most of the population would fall under the moderate risk group. So we've yet to define exactly what we mean by moderate risk, and I have a feeling it'll be narrowed down. Otherwise, it relegates the definition pretty, meaningless. If you have antibodies, do you still need the vaccine? That's a great question. And we don't know the answer. The thought is that because we don't know, like, certain levels of infection we think create a larger, more robust antibody response than other levels of infection. So, and I haven't heard anyone speak on that. My first instincts would be to say you don't need them, and you put you in the last sort of group. But we'll see as time goes on, as we get more data to figure out what's the reinfection rates. But to date, those infected, for the vast, vast majority, have not been reinfected, which would suggest that you don't need to be vaccinated if you have antibodies. Any comments on elderberry syrup? There's some interesting, looking at guaifenesin, elderberry, data looking at the antiviral effects. And I wouldn't take it on a daily basis preventively, but if I were to get infected, there is some data showing that it may be helpful. There's some other data suggesting that it could cause an increase of cytokine storm syndrome. But in general, people are pretty sick by then and not probably drinking elderberry in the hospital. So on the early part, as an outpatient, I think elderberry would be safe and maybe helpful. Who's going to be administering the vaccines? For me, for example, we're trying to procure vaccines. The minimum purchase is 1,000 doses. And so a couple of physicians are coming together, myself and a couple others, to see if we can procure those vaccines. We'd have to order 1,000 doses of them, which would be for 500 people. And so we're looking to see how easily we can do that. We know Walgreens and CVS will be distributing those vaccines as well. And we don't know the timing, neither do they, on when they're getting those vaccines. So we'll see how this all rolls out. It's sort of all happening in real time. Would homeopathic flu remedies help COVID? We don't know. The downside of homeopathic remedies is quite low. They're really safe. So something like oscillococcinum, I think, is a reasonable thing to take at the early onset of it. I don't think as a prophylactic it's been shown to be helpful, but at the early onset of it, of becoming ill. There's a question about inhaled food-grade hydrogen peroxide, if exposed, or using diluted, I think this is iodine solution as mouthwash. Yeah, I've heard people talk about it. I don't know of any research in humans about this at all. There's some, folks looking at it. I think there's some animal studies looking at it for other viruses, not for COVID. So it's sort of hypothetical at best. So I wouldn't do it. But I don't think there's any data, not good enough data to look at that. But if folks have any, please send it my way. I'm always interested in learning more. So if someone's donated a kidney, would they be at high risk? So only if you are on immunotherapy and you received a kidney and now need immunotherapy, you'd be at high risk. If you're the donor and gave away a kidney, you're not at high risk, because most people do just fine. If you're playing tennis, do I need to wear a mask? If you're playing doubles tennis, yes. If you're not in that pod or COVID bubble pod with that tennis mate, you should become in that COVID pod with them. Otherwise, you should be wearing a mask. They make these masks that there's one company called Broad Air, and there's other companies out there that have a HEPA filter that sucks air through the HEPA filter and blows it through a tube into the mask, so it actually delivers through positive pressure, fresh, purified through the HEPA filter oxygen into the mask. It's hard to exercise wearing a mask, so I would encourage someone to wear a mask using that sort of pushing clean air into the mask. Playing doubles, you're like right next to each other frequently. Unless you're planning to stay always at net and someone's always in the back where you're clearly separated, then you're fine. But often that doesn't happen. Do you need a vaccine if you're an alpha male? Good question. Most definitely, because you're probably walking into situations where that you shouldn't be walking into and getting yourself exposed. What's the URL for the survival calculator? I don't know. But if you go online, easy to find it. I have here COVID-19 survivalcalculator.com as a URL. So there's a few more questions I'll try and get to. Those that need to leave, I fully understand, but let me sort of quickly get to these. Will the vaccine decrease the risk of contracting COVID and or reducing the risk of transmission? Yeah, so the COVID vaccine is 90 to 95% effective in preventing you from getting sick. What we don't know is, does it prevent you from transmitting it to other people? So is it possible that the virus comes into your body and it can maybe, replicate enough that it then sits in your nose? You're not getting sick from it, but it sits in your nose because you have antibodies, but it's in your nose and you sneeze and you have it on your hands, and then you give it to other people by mistake. We don't know if that happens or not yet. We'll know soon because we'll be studying folks in clinical trials to figure that out, and hopefully in cohort studies as we're giving the vaccine, but we don't know, which makes me very concerned because we see how people behave when it comes to masks. Like, if they don't care about infecting other people and not wearing masks. Can you imagine now if you get vaccinated and people with that same selfish mindset, if they get vaccinated and they say, well, I don't care if I infect other people because I'm protected myself. So that's a bit concerning. And so therefore the current recommendations are, even if you're vaccinated, you should wear a mask because we don't know if you can infect other people. Well, I want to thank everyone for their attention. For those that have stayed late, I appreciate your interest, your attention. If you have questions, please feel free to send them to our way, and we'll do more of these as time goes on and help address any questions that people have. So take good care and please stay safe. Please do your daily self-care practices. Really do take care of yourself. Get good sleep. Do meditation, yoga, whatever it is that keeps you sane so you can sleep well. And I wish you all a safe and happy holiday and New Year. Take care.